So good afternoon, everybody. Really nice to see you again. This is a really important meeting for me, the Central and Eastern European meeting, and I'm really helpful to be here. And I'm Anca Streinu-Cercel from Romania, professor of infectious diseases and working in the field of HIV for almost 20 years. My theme for today will be to talk about advances in PrEP, and we will focus on what has been achieved and what challenges do we still have. These are my disclosures. So when we talk about where we are in 2024, looking at the data that the CDC published and looking for our area, Central Eastern Europe, we will see that the status of implementation of the PrEP, it's quite still a work in progress, so to say. By 2021, we have 20 countries that started PrEP guidelines and developed the implementation, but we have 10 countries that have the guidelines, but not the implementation. So to be honest, it's a work in progress, and we have areas like my countries where PrEP has not formally been implemented till this time point. But why do we think that PrEP is important? Because if we want to get to the targets of 0 cases by 2030, of 0 AIDS death by 2030, and 0 discrimination, PrEP is an important tool that we can use, and it can be something that we can rely on. So we can use it to eliminate new cases and look at the data. On the other hand, if we look at the data available, we have these are the most important issue that were identified regarding limitation in preventing and implementation of PrEP across Europe. So the cost of the drugs plays an important role, but we have some other issues that are identified as the second important step that are specific to each of the countries where PrEP is to be implemented. Also, STDs and the way that we only do PrEP for HIV is another important factor, but we have to look at group population that we need to target in different countries, each of our country. Again, because at this time point, we have focused on a population that is really important, where it all started, so the PrEP, where all of the patients that will do have a partner and are part of this group will like to access PrEP and know all about it. But we have some serodiscordant couples that are playing an important role. We have sex workers, and we have other categories like discordant couples in serodiscordant female-male partners, where we need to talk to them and we can address this, and PrEP can play also an important role. So what are the settings in our area? The majority of the PrEP clinics are in public health facilities. Majority of them are in infectious diseases clinics and sexually health clinics. So there is where the patient address, and there is where the patient are coming for help. We do have different case studies. There are models that really work well especially in Western countries. We have models from UK, we have models from France as well. We have countries where they have a lot of experience with PrEP, and we can learn and exchange experience from each other. But we need to adapt PrEP especially for our population. As you can see into this graph, the majority of the Western countries do have a lot of patients that are receiving PrEP at least once, and they are addressing the clinics. But as we move to the Central Eastern part, the number of patients, the population that receives PrEPs is lowering, and also the services are not available. So even if we look at the cascade on the right-hand side, where we need to identify the high-risk population, where we have the way to go to determine eligibility, and where we have the steps regarding how we should initiate, address adherence, and continue treatment or continue PrEP or stop PrEP regarding different issues for this patient. It's important to know that we still have a lot to work. On the other hand, I like this slide because I read the article that was published at the start of this year. They are the data from CDC, but what they have identified is there are challenges regarding optimization of the pre-exposure prophylaxis. But looking at the nice pies in this graph, we are looking that PrEP is used also and linked to higher educational attainment, to higher income population, and linked to insurance status. Yes, in Europe, things are a little bit different, but we still have some categories that may overlap them, where we need to look at our patient and need to talk to them about PrEP. We have models. There has been a lot of publication. I only checked the last ones regarding how we can approach our population and how we can differentiate PrEP service deliveries for targeted population, how we can look for male, female, sexual workers, serodiscordant couples, and how we can adapt to each of our cultures in each of our countries these models that can work better. Of course, they are fully available and everybody can look into that. And they are models that are a work in progress as well. So we need to look at them and look how we can implement them in the future. Regarding delivery channels, but it's an important issue that doctors, nurses, medical personnel is still in the middle of it, and you need to integrate into the provider options as PrEP. So we have achieved a lot in the last years, but we still have a lot to do because we have some future PrEP medication that we will talk about it. We have new options of the PrEP, not only oral treatment that needs to be taken twice on the day of pre-exposure prophylaxis and needs to be taken for different periods of time depending on the sexual activity of that person. We have injectables that are a game changer as well, and we have some topicals that may change the view of regarding PrEP for special categories, especially for women. So we all agree that PrEP is important and it's an important, potent tool. And looking at this data from the way to go near populations, near patients, near serodiscordant couples, again, it's an important. We also have some key principles that are on the basis of all the programs, the PrEP programs that work. We need to have everybody involved, and we need to have a team, and we need to have the patient, the population in the middle, everything in order to get it right, so to say. And the combination between other sexual transmitted diseases and HIV preventions really plays an important point. On the other hand, when looking at the population, there are some studies that have been published at the beginning of this year where we have the microbiome that plays an important role. And if you really look at this article that states that the vaginal microbiome and its potential to impact efficacy of HIV pre-exposure prophylaxis for women sounds like definitely it's more about how the drugs will affect the microbiota and regarding dysbiosis in this kind of a patient and how that will act on the long term of the PrEP that is available for this kind of population. So we really need to look deeply when we read a title, look at the data that are available, and think also about how some of the treatment may affect some of the population that we are addressing. So just to sum up the data that we have in our region, we have a lot of patients that are newly diagnosed. And from these patients that are newly diagnosed, if PrEP will be working in our area, I think we will have less and less patients because on the table on the downside, we'll still have a lot of patients that are diagnosed and a lot of patients are late diagnostic patients. That means that they have been infected for a longer period of time, and that from the point of view of transmissions means that they had enough time to transmit the virus. So definitely if PrEP will be available, we will have a tool in order to prevent that. So we have an actual plan from ACDC that has priority for actions and where PrEP is an important tool and plays an important role in the goal of ending AIDS epidemic by 2030. So we can rely on that as well. We do have the problems of migrants and the availability of PrEP for them, an undocumented migrant, it's another issue that we need to rely, because the map in our area, it's kind of gray. That means that we do not have these services available at this time point for our population and for the patient that may address these services. So in order to close this short presentation regarding PrEP, where we are at this time point, what we have achieved and how we will look at the data. I didn't talk that much about the availability of the PrEP and what is the treatment available, but I would like to look at this cartoon regarding the years ahead in HIV prevention research and focus on the availability of the treatment that we do have at this time point. So we have the recommended treatment with TDF and FTC for all our patients in the clinics that are available, but we may have some options in the near future. We have talked in previous years regarding the vaginal ring with dapavirine, monthly dapavirine, and we have some multiple regulatory improvements starting 2022, and in the years ahead, definitely it will play a role in female patients regarding the PrEP as an option for them. Then we have the long-active injectables that really were a game changer, starting with cabotegravir, that was 1 intramuscular injections every 2 months. We do have the studies, we can deeply discuss the results, but what I want to emphasize is the fact that we have demonstrated high efficacy. And yes, we may have some issues, but it's a little bit more different than what we had in the past with 1 pill. And lenacapavir with the studies with purpose 1, 2, and 3, 4, and 5 will really be a game changer, because lenacapavir has 2 subcutaneous injections every 6 months in order to have the PrEP availability in the near future. And you will see on the top of my slides what will be the years when we will be talking about that. As oral PrEP tough, it plays an important role, and there are some countries where it is available as PrEP as well. But we have a new molecules from MK-A527 that is a drug, 1 pill monthly. And the study has reached 2A phases and looking for the starting of the next year, if they will move forward with the decision to go into phase 3 clinical trials. It's a new drug from a new mechanism of actions, totally different from what we know at this time point. And we will have the co-formulation of TDF with oral contraceptive pill that will be 1 pill that will address the 2 of them. Again, another way of trying to prevent and trying to get near the patient in order for them to get access to treatment. And with this slide over here, I would like to thank you for your attention and thank you for the time talking to us, and open the discussions for any questions that we might have, because definitely we will be talking about what will be the changes that still remain in the near future. Thank you so much.